Ladies and gentlemen, you're welcome to the next session of head and neck malignancy. We are going to present Professor
Nancy Lee.
Dr. Nancy Lee.
And now we'll start with the first session, de-escalation of the human papillomavirus positive oropharyngeal carcinoma by Professor Nancy Lee. Professor Nancy Lee is a well-known vice chair of the Department of Radiation Oncology in the Mammalian Soren Cancer Center, and also the editor in the Practical Guidelines of Radiation Oncology, our famous book, our reference in contouring, and also his editorial board in the Journal of Radiation Oncology. Can you start that talk, please?
Hello, my name is Nancy Lee. Thank you so much for having me. Sorry, I could not make it to Egypt this time, but perhaps in a future time. I want to give you a topic and discuss in the next 15 minutes something that's very dear to me. And I think this is how we as radiation oncologists should think. How can we rethink how we approach radiation oncology? And I like to use human papilloma related oropharyngeal cancer as a model. And the idea is really that we are going toward a biologically driven, information driven precision radiation. Here is a picture of a linear accelerator, and you can see that here's the radiation coming down, but what do we target? We target the DNA, and this is where the biology is mixing with physics. And this linear accelerator could be proton therapy, could be MR-Linac, could be brachytherapy, could be tomotherapy, cyberknife, anything you name. The idea is how can we combine physics with biology together to personalize our radiation therapy. These are my disclosures. I'm in a bunch of advisory boards. Now, before we begin talking about personalization, we need to look at what is the current standard care for HPV positive driven cancer, and then look at some of the current de-escalation approaches. Why? Because this disease does so well with standard chemoradiation, which led a lot of groups to think about de-escalation strategies. I'm going to talk about some of the failed attempts and some of the ongoing attempts. And then in the end, talk about how we can personalize therapy for this disease. HPV-driven cancer is more virally driven cancer. It's really the non-smoker, non-drinker, marijuana use, higher socioeconomic class versus the HPV-negative smoker, drinker disease. These have very, very two different prognosis. When we look at the HPV structure, it is a small non-enveloped double-stranded DNA. It's circular, approximately 8 kilobase pairs in size, and encodes 8 major proteins, 6 located in the early region and 2 in the late region. And for all purposes, the oncogenic drivers are really E6, E7 oncogene of the HPV virus genome that causes cancer. When we look at the prevalence of HPV oropharyngeal cancer, you see it's increasing compared to the HPV negative. And then more importantly, you can see oropharyngeal cancer is the #1 rising cancer compared to your oral cavity, your larynx, other pharynx. So indeed, it is a situation that we see now where perhaps later on we can talk about vaccination, how we can decrease having any incidence of this disease. So when we look at HPV positive tumor, they do typically better than the HPV negative counterpart. You can see the curve really separate. And then here, this is MSKCC data. You can see that OPC really do pretty well. We hardly have any failure. The control rate is in the upward of 95%. But when we compare to, for example, oral cavity cancer, we have about 20% recurrence rate, but despite less effort. The disease is so good that it made us change the staging system. I don't particularly like the staging system, but it is the 8th staging system that started in January 2018. We were part effort for this, but in the end, what we really realized, time will tell whether this is really a better staging, because you can be full. You have a T2N1, and this N1 could be multiple lymph nodes. You think you're stage 1 RT alone, but data will show you that you cannot treat this disease with RT alone. So let's look at the summary of the current status. We have the most accepted standard care, that is concurrent cisplatin with 70 gray or 7 weeks of radiation, or alternative is surgery followed by postoperative radiation, 60 to 66 gray plus or minus chemotherapy. This leads to a lot of acute and late complications, to a point that there are a lot of efforts to reduce toxicity. You go to any head neck meeting, whether surgery, med onc, radon, there's going to be a topic on de-escalation for this disease. Patients have many options. Frankly, I think causes a lot of confusion. And then there are numerous de-escalation trials that are ongoing, and I will talk about some of the failed attempts. Approach number 1, let's look at how, if we say this disease is so sensitive, how can we get rid of cisplatin? It's a wicked disease. What is cisplatin? Well, it's an alkylating agent. It's able to cross-link with the purine bases on DNA, interferes with DNA repair mechanism, causing DNA damage. But when we introduction of cetuximab, a monoclonal antibody directed against EGFR, we have found through this randomized level 1 evidence that cetuximab plus RT is better than RT alone. And of course, FDA approved this drug indication. We started using as well, but we only found that compared to cisplatin, we had a lot more failure in cetuximab versus our cisplatin cohort. And if you look at disease-free survival, patients that have cisplatin is much better than cetuximab. Now, this is all common for head neck cancer, but Riaz in this AJCO article looked at HPV status only and still continues to see the separation of these curves, that basically platinum still indeed did better than cetuximab. And now we know in 2019, 2 level 1 evidence, one from RTOG, another from De-Escalate United Kingdom, show that cisplatin is indeed level 1 evidence better than cetuximab, even for early stage oropharyngeal cancer. So we know that cetuximab didn't work, and then that cisplatin is still the standard care. How about, let's think about something very hot right now, which is immunotherapy. Why don't we replace cisplatin with immunotherapy? Well, this is what Dr. Su Yam trying to do in this RTOG study, where there are 3-arm randomized phase 2 study, where you can see 70 gray with 6 fractions per week, an escalator RT with platinum, or 60 gray with standard RT with platinum. And lastly, the 3rd arm, which is really standard fraction of radiation, but escalated, plus nivolumab, which is anti-PD-1. The results are still pending, is still accruing. Or how about this key chain study by Lauren Mill in UCSD? Similar concept, but include a lot bigger tumors and a lot more tumors, including those that are not OPC. And you can see standard arm platinum versus a single agent pembrolizumab for 20 cycles. This is Merck's anti-PD-1. So you have these 2 studies ongoing, and we will know the result. However, I really am worried. This is a Javelin study that I published, looking at anti-PD-L1 added to chemoradiation. Not only did we not see an improvement upon standard chemoradiation, we saw possibly a little detriment. Why is that? We have no idea. And there are since then at least 5 randomized studies also showing they're all negative, one of which is just presented at ESMO, which is Keynote 412, looking at single agent pembrolizumab added to chemoradiation versus chemoradiation. Again, it did not meet its primary endpoint. It was a negative study. And then in cervical cancer also is a negative study. So it really tells you probably not a good idea to combine immunotherapy with radiation concurrently. So conclusion to date, if we want to replace platinum, we can't. It is still the standard of care for HPV positive oropharyngeal cancer. And time will tell whether single agent anti-PD-1 can replace this platinum. How about just drop platinum? Remember earlier I talked about radiation only. What if we just drop platinum since it's such a wicked drug? This is a study by Su Yang where they looked at weekly cisplatin with 60 gray versus escalated RT dose, RT alone. and to only find that there is more local regional failure in patients with RT alone. So therefore, we cannot drop platinum. And then similarly, as you can see in the progression-free survival. So we cannot drop platinum. We need cisplatin. We can't replace it. We still need cisplatin. The question is, how do we get platinum? Is it weekly? Is it every 3 weeks? This is an ongoing study that's going to be answered probably in the next 5 to 6 years or a decade to say, should we do high dose? Should we do weekly? My answer to this is I think it's going to be equivalent. I don't think we're going to find a winner. Okay. Now, how about third approach? Let's use induction chemotherapy. Can we consider giving some cocktail first? And here we see paclitaxel and cetuximab. And then we will then have the algorithm of de-escalated therapy versus standard if you're non-responder. Results are great, but it's prolonging treatment. So I'm not sure that de-escalation is occurring when you have 3 extra months of chemo, when you do just as well with chemoradiation. But you can consider for large T4 disease. This is data from Mount Sinai. They had 70% patient with T4 N3 N2C disease. Perhaps this is a way to consider de-escalation for even more advanced tumor. How about looking at surgery approaches? This is ECOG 3311 robotic surgery. And then there's a kind of algorithm on how we should give radiation afterwards when, if you don't have any risk factor, you observe, you have some risk factor that's intermediate, not positive margin or ECE, you can be randomized to 50 or 60. In our center, we have drunk the Kool-Aid, we're going to do 50 gray. We treated many people at 50 gray, we haven't had any failure. If you're high risk, you have positive margin ECE, you still need greater than 66 gray plus cisplatin. And Orchard 2 showed in a randomized study whether you should do surgery upfront or just chemoradiation de-escalated. And we found that indeed in their TORS arm, there's more bleeding. And the bleeding isn't so much worse than the Orator with ECOG 3311. It really begs the question, do you need to have surgery? Of course you do. I think we just need to be smarter. And I think the key is first, do not have triple modality. So a person get surgery, chemo, radiation. We have done a disservice for the patient. So patient selection is the key. So we have this really smart trial, really cool, with a moderate after prostate cancer. We operate, and then we find some pathologic feature, and then we obtain cell-free DNA, and then if you're undetectable, you will be observed. So very safe way of de-escalating, just giving surgery only. This is an ongoing pilot study. Hopefully we will not shed the answer in a couple of years. How about RT technology? Of course, we can use proton. As you can see, this is proton versus IMRT. On the picture, I don't have to tell you, you get more delivery to normal tissue with IMRT. And then the only way we will definitively know the answer is with Steve Frank's study, which is a 400 plus patient randomized study. This a complete accrual. We should know the result next year, whether IMPT is indeed the same or equivalent to IMRT. And how about something that we can do now? Why don't we de-escalate the microscopic region? This is what standard MSKCC way we treat 70 gray, but first we start 30 gray to all subclinical region. And then we don't treat level 1, B, or 5. And then we boost the next 40 gray, which is next 4 weeks, just to the GTV. So you can see you have a very low subclinical disease of 30 gray with chemo. So we start thinking, why did we get so worried? Why did we escalate our microscopic disease to even 63? It's too high with chemo. So right now, we really need to be rational. We find that at our center, 30 gray was sufficient. And to summarize, I gave you a lot of options, but they all treat the gross disease or post-op bed to a very high dose of radiation. And more importantly, it is not personalized. So what can we do in 2023? Hence, we have the precision radiation oropharyngeal cancer trial or the 30-ROC trial, reduction in oropharyngeal cancer. The question I ask is de-escalation for all HPV positive tumor? Are they all the same? I would say no. Look at this HPV positive cell line after 2 gray of radiation versus this HPV cell line after 3 grade of radiation. You can see the repair capacity for both of these are pretty similar. So begs the question, not all HPV positive disease are the same. Some behave like HPV negative. And then goes in clinic, why should we treat everybody the same? Why? After all, does one size fit all? I don't think so. Everyone's genetically different. Here, I call your attention to a great paper by my colleague Nadine Riaz, looking at 3 buckets of why HPV positive tumors radiosensitive, looking at hypoxia, DNA repair, and the immune response. I'm going to focus on hypoxia. What is hypoxia? It's low oxygen. It's a robust biomarker across multiple cancer, preclinical, clinical, across multiple disease. It portends radioresistance, assess multiple different ways. The most practical way is non-invasive way, and with a single tracer F-myso PET, we're able to assess the hypoxia status of the tumor. We have a longstanding interest in hypoxia program project at our center. We started to say, if you're hypoxic, which is showing red, but if you have early resolution of these hypoxic regions, then we initially thought you were a candidate to only go to 60 grade, drop by 10 grade, very safe way. And then we even biopsy these regions and found not everything you see in red should be cancer. We track the needle is tumor. Some of it is just stroma, it's normal tissue. So it begs the question, do we need to treat everybody to such a high dose? We stopped at 60 grade here because it was very early on. And then the question really is, what else can we do? And we look at hypoxia, another group published this, that it is smoking was important in univariate analysis, but not in multivariate analysis, was hypoxia expression continue to be positive, measured by HIF1 alpha immunohistochemistry. And you can see there's a 6-fold difference in hazard ratio in favor of non-hypoxic tumor. And then I call your attention to here. If you're HPV positive, and you're not hypoxic, you're going to do much better than if you're hypoxic. So if you're going to design a de-escalation trial, you want to focus on the group that has no hypoxia. So the question then is, how much lower should we go? What is a safe de-escalation dose? Well, first, it must be safe. And second, it must be meaningful, because if you de-escalate it by 10 grade, it's not exciting. You're still having a lot of toxicity. And here, that's when I thought about an aha moment, thought back to my residency day, Dr. Nigro, who treated HPV positive anal cancer with 30 grade and 5-FU mitomycin C. So we said, you know what? Biology trumps sight. So we took a leap of faith and we said, we're going to give 30 grade in non-hypoxic selected patient. We're going to keep chemotherapy because it works, platinum works on the DNA repair pathway. It makes sense. Double whammy, killing the tumor. So we had this pilot study. First, we asked the surgeon to take out the primary so we can do all the sequencing, whole genome sequencing. We asked them to keep the lymph node. If there's no evidence of hypoxia, we gave 30 grade, 2 cycles of platinum, and end the radiation. The lymph node still there. We follow monthly with MRI, had a mandatory neck dissection. We include all smokers. We had tons of correlatives, cell-free DNA, even financial toxicity. We hope to share the result here with you. I had 3 surgeons who were willing to work with me initially. It's a crazy concept in 2015 to only give 30 grade. Here's an example of a patient FDG positive, but F-myso negative. We de-escalate to 30 grade. The patient's NED about 4 years out. How about patient hypoxia positive, FDG positive, hypoxia positive here? The result, again, 30 grade. Patient's doing very well. But how about someone FDG positive, F-myso positive, but you see evidence hypoxia? Then we said this person is not safe to undergo de-escalation. We should go to 70 grade. You can see the night and day. 70 grade patient, more sick, weight loss, lots of toxicity, longer recovery time versus 30 grade. We wrote this proof of concept pilot study published JNCI a couple years ago. And what we did is out of 19 patients, we were able to de-escalate. 19 patients de-escalate about 15 patients, which is about 80% of the cohort. And then we found this pathologic response. Essentially, everybody responded, and not everybody had complete pathologic response. Mainly few that were not, and I'm gonna go over that. We looked at cell-free DNA. We didn't think it was correlated with pathologic response. You can see it's all over the place, consistent with Bishan Chira from UNC, that they needed to wait until 4 weeks into chemoradiation to have cell-free DNA clearance. But by then, it's too late for us. Remember, we already de-escalated at week 3. So that's not a good marker. How about volume? Here's week 1, week 2, you still see the volume here, and you need to make a decision. Do you want to de-escalate or not? This is something that you can. And therefore, volume is not a very good predictor. How about IVIM? Intravoxel volume incoherent motion, where we break into perfusion, diffusion, kurtosis. We look at K-trans, marker of permeability and perfusion. It seems like there is a difference, significant difference, and even kurtosis and tissue breakdown. The relative change, more tissue breakdown, the better you did. And that's what we've done in the MRI space. And how about DNA repair space? We see that these tumors have a defect in non-homologous end joining. So in other words, radiation hits the DNA. The DNA needs to repair. NHGH is the major pathway that repair radiation-induced damage. HR is mainly responsible for cisplatin damage. But when you damage the repair pathway, what does the tumor do? It still wants to repair itself. It seeks an alternative, more error-prone pathway to repair itself. And we can measure the signature. And you can do that by looking at the mutational signature using whole genome sequencing. You can't see that on exome. You have to go deep to look at insertions and deletions. And we found indeed the responders had a higher deletion with microhomology than the non-responders. We also looked at it with Mayo Clinic data. We also found that it was significantly different among responders versus non-responders. So, and then it's interesting, which I love this, patients that are responders are less clonal. They're simpler. Look at the circus plot versus the responders, non-responders, sorry. They're just more clonally, subclones, and then they're very complex structure in this circus plot. So we saw that among HPV, this is a genetic reason. That might also like the phenotype. Here we're looking at the genetic reason why they responded to 30 gray or not. And lastly, of course, we need to talk about immune system. There's a really nice paper by Ash Shamsuddin on tumor immunity and immunotherapy for HPV-related cancer. HPV-specific antigen can downregulate the MHC1 to prevent T-cell recognition, as well as regulate the CGAM STING pathway, which is important because it stimulates the interferon gene that will stimulate innate immunity. And so that's another reason. Regulate the P1, PD-L1 pathway, and it will downregulate ERF3, leading to decrease in type 1 interferon gene, and which is important for death of these cells, where it's eliciting immune T cells to activate T cell to kill the tumor. So here we see there's the innate immunity pathway and there's the adaptive immune pathway, multiple reasons why these tumors do well. So this is an area of heavy investigation. So those are sort of some of the preclinical work that we're doing, or even using the clinical data and try to decipher genetic reasons why we found 30 gray to be effective. Now we're going to go back to the clinic. So since the pilot study, we have enrolled. We no longer mandate neck dissection. We had the primary to the tumor. We now have all the surgeons bought on, willing to do. It's in fact the most popular protocol we have in our center. We started with 158 patients. We're able to de-escalate 128 to 30 grade, only about 80% of the patients. And then results were just absolutely amazing, over 90+%. And we're able to salvage everyone. Here's a patient. Don't jump to neck dissection quickly. He's pre-treatment lymph node. 1 month into it, it blew up. Very, very scary. And then it went away. It just melted like that. So 3 grade month. So the patient's NED about 2 years out or 3 years out now. We still follow him in Florida. So this is very important to know that take time. This is a viral-driven disease. Don't be so quick to jump in to do what you need to do. An FDG positive PET. clean, but in 8 months it recurred. F-MISE was negative. So then we were able to successfully salvage him and not giving any adjuvant therapy. If you catch early, you do not need to give any adjuvant therapy. Patient quality of life, they had a little dip in week 3, but by week 19, month 4, they're back to normal with a global, emotional, functional, physical. And since then, we have completed cohort 158, and we also completed cohort B. This is actually 148 out of 148. We're going to pilot in our MSK Miami, where we're going to generate the compound in New York, fly down to Miami, and have the patient be on the same protocol. And this is our radiation oncology and medical oncology team. And then we have the next iteration, which I opened already. I'm going to just treat the GTV only. We're not going to treat subclinical region. So we're shrinking the volume. First the dose, now just shrinking the volume. And then the next question is, does it have to be 30 versus 70? Very binary. Could there be some people that only need 40? They can't do 30, but need 40 or 50. And then treating the volume only, you can see how much you can decrease toxicity. Long-term plan, we have to talk to FDA. We have to propose to Energy Oncology. We need to standardize F-MISE reading. A data will come out of ASTRO this year. And then we need to follow on the NCCN guideline. And then ultimately to do a randomized study to compare whatever the standard care against 30 Rock precision radiation pathway. And then in the end of the day, that's all good. But how about if we screen? We know screening study for cervical cancer did well. People that were screened and that were vaccinated did very well and didn't develop cancer. So we have a virally driven HPV positive related cancer where we're trying to develop screening tool for HPV related cancer. Very complex algorithm that we want to go through. If we find normal subject with cancer early, they never need to have any treatment. And then we want to intervene by probably give them vaccination if they have possibility of developing cancer. Those are all ongoing effort. The plea I have is get your children, especially young people, to get HPV vaccine. It's preventable. It's like COVID. You can mild symptom right here. You can prevent the cancer from coming. Again, I want to leave with you this concept of biologic-driven disease. If you think about it, we need to transform the practice of radiation oncology from an impaired blunt tool, everyone gets the same dose, to a biology information-driven targeted therapy. In other words, we find the biomarker, we use radiation as a targeted therapy, we dial down dose to the precise dose it needs. And that's how we can combine biology with physics. This work is not possible without an entire team of people working together, a lot of it behind the scene, to make sure that we can truly go toward precision radiation. I really want to thank you for having me here. And if you have any questions, feel free to email me. My email is oeen2@msacc.org. And thank you for your attention.
Okay. Okay. Thank you, Dr. Nancy Lee, for this excellent presentation. And because of limitation of time, we'll move to next presentation. Dr. Anna Castro. She is oncologist and chairman of the board of Algarve Hospital and University Center since 2020. President of Health Parliament Portugal in 2019. President Portuguese Head and Neck Study Group since 2014 until 2020. Okay. Can you hear me?
Yes, perfect.
Okay. You can start.
Good afternoon. Good afternoon to everyone. Thank you for having me here with you. And I will try to make the journey with you in the setting of the recurrent metastatic head and neck cancer. So when you have a patient with a recurrent metastatic disease, you have to think about what is your main goal, because Of course, first of all, you want that your patients live longer, but still there is different things you have to consider. You have the symptoms, if the patient is symptomatic or not, and if you need to control those symptoms, if you need that the tumor shrink very quickly because the localization, because of the effects that this recurrence has for the patient, and extend survival. Of course, everyone wants that their patients live longer, but most of all, the quality of life. So we have to keep on our minds that the patients should live longer, but should live better. And you have all these specific tables that could help you deciding. And I will try to make these more simple. Let me say, if I can do it. So you have to have now the CPS score. It's mandatory for deciding the treatment. And you can divide the disease in two parts, in need of response or stable disease. And if you consider in need of response, independently, or if you don't have CPS score, what you have for first line, you can have Erbitux plus cetuximab or pembrolizumab plus chemotherapy, because those patients need chemotherapy for sure. And what you can see is that consider the different CPS scores, so more or equal to 20 or more or equal to 1. What you see is that when you combine chemotherapy with pembro or chemotherapy with cetuximab, the patients have different progressive disease rates. So you can see that when you use extreme regimen, the patients have less progressive disease, so they have a best response in their treatments. And then if you consider the whole journey of the patient, so if you have pembrolizumab plus chemotherapy, after this, what do you have in second line? So monotherapy, other combinations, you don't have this data. So this data of second line is very important in this new setting of treatment. If you do extreme, or if you do TPEX, that is a different regimen, even with a better results for your patients with less chemotherapy, you have in second line immune checkpoint inhibitors with nivolumab or pembrolizumab. You can do both, and depend of the approvals in each country, but you can have immune checkpoint inhibitors, and you have the median overall survival. If you do these combinations, is 21.9 months. This is a very good results for those kind of patients. But consider stable disease. So you have time for stable disease. You have time for the patients to respond. And considering CPS more or equal to 20, pembrolizumab monotherapy. Why pembrolizumab monotherapy? Because you can see that the overall survival is good, is even better than when you use extreme. And if you compare with the pembro plus chemo, you don't have different results. And pembro monotherapy is much less toxic than with combination with chemotherapy. So if you have time, you can have pembrolizumab. Remind always that the first 6 months are very important for our patients, because if you look into the PFS, you see that the first 6 months is the ones that the lines cross. And so you have to be very careful with your patients, because you need to be very sharp detecting progressive disease. Otherwise, you will lose your patient without any chance of a second line. And if you do a second line therapy with the cetuximab plus chemotherapy, you see that even for second line after immune checkpoint inhibitors, you still have a good overall response rate for these patients. So you can see that the combination has 53% of response, and the other ones 25%. The other ones with stable disease but CPS lower than 1, for those you cannot use immune checkpoint in first line. So you have cetuximab plus chemotherapy and then immune checkpoint inhibitors for those patients. So you can see that the results show no benefit for those patients that has CPS lower than 1, and it favors PFS with extreme. Those patients with CPS between 1 to 20, So those patients are the ones that can be eligible for chemotherapy plus pembrolizumab or cetuximab plus chemotherapy. And if you look into these graphs, so you can see that the benefit from pembrolizumab plus chemo or only monotherapy is higher when in overall survival and PFS and overall response rate when you increase CPS from 1 to 20. And if you consider extreme, the benefit is independently of the CPS expression. So this is the data. So then you have, if you need a response, you see here that higher overall response rate with extreme than with pembro monotherapy. And if you look into these patients, so when you do pembro plus chemotherapy, they have chance to have subsequent therapies if they are submitted to extreme in first line, then if they have pembrolizumab plus chemotherapy. And I think these are data that is important because we need sequencing data to decide what we should do to our patients. If you see the second line in immune checkpoint inhibitors, you can see the results from Checkmate 141 with nivolumab, and you can see that you have a median overall survival 7.1 months. So this is really good, and if you look in real world data, they are even better. So I think the patients will benefit for this nivolumab treatment in second line. The point is that when you look at the results, and if you talk about Keynote 048 and so on, the median PFS, I think this is not the best data to decide. And at ESMO, they presented the data for 048 and 040, actually. And you can see that the overall survival still is better than with extreme. But one thing that we can point out is that is a little bit strange that the result of median overall survival of extreme regimen is exactly the same on the original approval trial with extreme, that is 10.7 months median overall survival. And this is strange because there is a lot of other second line treatments with immune checkpoint inhibitors. And if you consider even the trial of TPEX, you didn't have 10.7 months on median overall survival in the extreme arm. You have 14 months. So it's a little bit strange, these data. So I think we need more data about sequencing treatments and what the patients were allowed to do in second line, so we can decide better the best treatment for our patients. Because the benefit that you have in immune checkpoint inhibitors in second line is a good benefit. So you have 21.9 months in this TPEX study, and even for extreme, you see 19.4 months. And I think this is still data really interesting, and with less chemotherapy, because TPEX only has 4 cycles of chemotherapy combined with cetuximab, in spite of the 6 with the platinum and 5-FU that you have in extreme and in pembrolizumab plus chemotherapy. If we look into the data of this trial of TPEX, you see that the overall survival at 12 months, when you have a patient who have a second line with chemotherapy-based therapy, you see they have 67% of the patients are alive for 12 months versus 78 for the ones who have immune checkpoint inhibitors. And if you consider 24 months, you can see there is 27% versus 37%. So those are good results. We are talking about 2 years overall survival for a patient who have been submitted to a second line treatment for recurrent metastatic head and neck. So this is a very good news. So considering the most appropriate treatment sequence for each patient, I think these treatment decisions depend on the patient needs, on the disease characteristics, and if you need a response or not. It's important the patient has a very quick response or not. And patients should have the opportunity to receive both Erbitux and immune checkpoint inhibitors in their treatment journey. This is for sure. They should have the opportunity to receive both. And the efficacy of chemotherapy plus pembro in patients with higher CPS leads us to have access to the CPS score before you start treat the patient. It is very important too. The high response rates and the low disease progression associated with chemotherapy plus cetuximab allows patients to receive several lines after this first line and could extend overall survival with a good quality of life. And the use of immune checkpoint inhibitors in the second line did not negatively impact the outcomes on the patient. So I think we have a lot of gaps remind those trials, because you have one in first line and the other one in second line, but the patients are not the same, because if you have it in first line immune checkpoint inhibitors, you didn't have in second line, and by the other way in the second line is still true. But we need now the answers are in the which is the best sequencing treatment for our patients. And the other thing that I think we should be aware is that we want them to live longer but live better. So please, we need to think about and not having all together, because it could be too toxic for a patient that is not in a curative setting. So I think we have to think about in the way we design the trials to try to sequencing more than to use everything at the same time for the sake of the patients and for their quality of life. And that's what I bring to you. Thank you so much for having me here.
Thank you. Thank you very much, Professor Anna, for this intelligent presentation. And now the floor is open for any questions. Okay, I have a question actually. Was there any indication about the usage of radiation therapy as a salvage in some few cases that you used either immunotherapy or systemic therapy?
In our clinical practice, we use radiation for the patients who have small lesions or residual disease, a very small lesion that could have radiosurgery. But it's not, you don't have evidence, clinical evidence that could help you deciding this. But of course, if the patient has a very good response and only has one small lesion, we discuss with the radiation oncologist, and most of the time we do radiosurgery for that small lesion.
Thank you very much. Thank you, Professor Anna. And now we will move to the next speaker. From Egypt, we have Dr. Tugan Taha. The title of her presentation would be Additive Value of Neck Imaging Reporting and Data System in Post-Treatment Surveillance. Thank you very much.
ماشي مش هشوف كده كويس، بس هو نايم كده ليه شايفه كده، بس سيء ابدا مش شايفه كده. بسم الله الرحمن الرحيم. الأول بشكر أساتذتي وزمايلي على الدعوة الكريمة ديت. Today, I want to highlight the story of NIRAD's head and neck structural report, and I want to present some selected cases from our daily practice. Taking into consideration that recurrent disease is a barrier to long-term survival in head and neck cancers, post-treatment surveillance should be focused on detecting early recurrence, and the choice of MRI or CT is determined by the disease location, patient-specific clinical concern, and the questions needed to be answered by imaging. So, what is the aim of NIRADS? Is to standardize terminology, report organization, assessment classification, to standardize approach with linked management recommendations, to provide numerical levels of suspicion to guide patient care, and we have binary outcome, cancer or not. This is a case of T2NOMO glottic carcinoma in the pre-treatment imaging. This is the initial regression in the first follow-up, but the second follow-up, there is progressive thickening in the interarytenoid region. Is this progression or post-treatment change? This was reported as progressive disease, and biopsy revealed chronic laryngitis. This is the next MRI with more progressive edema, thickening, and obliteration of the airway. So why NIRADS? Because the radiological diagnosis is not always straightforward. A multidisciplinary team created a standardized template for the surveillance of the post-treatment head and neck cancer centered on the lesion size, the depth of invasion, the FDG avidity, and the linked management. And so the head and neck imaging reporting and data system, or NIRADS, was developed for the surveillance of treated head and neck cancers. We have certain categories in NIRADS according to the degree of suspicion. In category 1, there is no evidence of recurrence. We have expected post-treatment changes, either tissue distortion or scar. In NIRADS 2, we have low suspicion of recurrence with ill-defined, mild enhancement, low FDG uptake, or if we have a discordant between the contrast-enhanced CT or MRI and the PET-CT. For example, we have robust enhancement in the CT with no FDG uptake, or focal FDG uptake with no anatomical correlate in the CT. In category 3, we have high suspicion of recurrence with discrete lesion, new or enlarging mass, or intense FDG uptake. And in NIRADS 4, we have definitive recurrence with pathologically proven or clinical or radiological definite progression. The NIRADS categories are designed for use after definitive or curative treatment and not to be used during the treatment. The guideline for PET and CT MRI discordance only applies if the original tumor was FDG avid. If the primary tumor is unknown, this is P unknown primary is suggested. If the primary cannot be assessed due to dental artifact, motion, or other technical issues, or outside the field of view, so this is PX. In the MRI examination, we always have tailored protocol to a specific area of concern. For example, the skull base for perineural tumoral spread, and sometimes the entire neck not be imaged. So if the neck cannot be assessed, so we can suggest NX. So what are the NIRADS linked recommendation? In NIRADS 1, we have the routine surveillance. In NIRADS 2, direct inspection if it is mucosal lesion, or close follow-up or PET-CT. In NIRADS 3, do biopsy. In NIRADS 4, treatment of the recurrent disease. So we have a NIRADS template that findings are briefly and efficiently reported, saving time for the radiologist. In the impression, NIRADS category is assigned for the primary tumor site and the nodal disease separately, as they are managed separately. A ligand is included in the bottom of every NIRADS report, so allows interpretation by any clinician viewing the report with direct guidance based on the category, making NIRADS accessible to any physician. So what are our lexicon in NIRADS? For the primary tumor with no mass, so NIRADS 1, non-mass distortion of soft tissue and fat planes. If we have mucosal abnormality, either smooth linear enhancement or mucoid density, so we are still in NIRADS 1. But if we have a mass in our scan, if this ill-defined mild enhancement, so this is NIRADS 2. If it is discrete with robust enhancement, so we are dealing with NIRADS 3. In the lymph nodes, we have two categories, either residual nodal tissue, which was there in the pre-treatment scan, so no FDG uptake relative to the background. I will categorize it as NIRADS 1. If mild FDG uptake relative to the ground, so this is NIRADS 2. And if intense FDG uptake relative to the ground, so this is NIRADS 3. The next group is the growing nodal tissue, which was not present in the pre-treatment scan. So if along the expected nodal drainage without definite abnormal morphology, I will categorize it as NIRADS 2. But if with abnormal morphology, as in this patient, so I will put it as NIRADS 3. And if with intense FDG uptake, this is NIRADS 3 or NIRADS 4. This is a case of T2N1 tongue squamous cell carcinoma in the pre-treatment study with right lateral tongue malignant mass and ipsilateral lymph node. And here is the post-treatment surveillance with no mass and no pathological lymph nodes, and it was categorized as NIRADS 1 for the primary and neck. And this is a case of T3N2 hypopharyngeal squamous cell carcinoma. The post-treatment surveillance, there is ill-defined soft tissue mass with mild accentuated enhancement, no discrete nodule or growing lymph node, and the FDG was mild FDG uptake, and it was categorized as primary NIRADS 2 and neck NIRADS 1. This is a T4NO transglottic carcinoma in the pre-treatment scan. The post-treatment scan shows ill-defined soft tissue mass with only mild differential enhancement. So we recommend a second modality to visualize the nature of this lesion, and the MRI reveals bilocular abscess. The discordant between the MRI and the PET-CT, as in this case, there is focal FDG uptake with no anatomical correlate in the MRI. The MRI shows only mucosal enhancement and mild edema in stir, so this was categorized as NIRADS 2 and neck 1. The diffusion-weighted images is a crucial missed diagnostic tool in the NIRADS. Here is, in this case, there was a focal diffusion restriction corresponding to the FDG uptake in the same patient. This is another case with T3NO tongue squamous cell carcinoma in the pre-treatment scan. The post-treatment scan shows focal enhancement at the operative bed or the primary tumor site, and there is newly arising necrotic, malignant-looking lymph node, so this was categorized as NIRADS 3 for the primary and for the neck. And here is the PET-CT with avid FDG uptake in the primary tumor site and the malignant lymph nodes. In NIRADS 3, take care the radiation injury to the soft tissue or bone can be tumefactive with false positive results. generally call NIRADS3 when willing to do biopsy. To differentiate NIRADS3 from 4, work backward. Does this lesion need a biopsy? Is there anything it could be? If no, so this is NIRADS4. As in this patient with maxillary carcinoma, here is the pre-treatment scan, and this is the follow-up with marked progression of the mass and extension and the mass effect. And here is the PET-CT with vivid FDG uptake. Does this lesion need a biopsy? Is there anything it could be? No, so this is NIRADS4. The recurrence rate among NIRADS categories, as expected, higher in NIRADS3 than NIRADS2, and it is the least in NIRADS1. So to summarize, NIRADS simplifies the communication between the radiologist and the clinician, clearly directs the management, gives several ways to influence the patient's care as direct inspection, short follow-up interval, additional modality or biopsy. And sometimes we are not sure of the diagnosis, but need to be sure of the next step. Thank you.
Thank you very much for this brainstorming presentation. Actually, it's we need it. It's very helpful to take the right decision on the right time for the patient. And now the floor is open for any questions. Yes, please.
Thank you, Professor Togan. Please, if you can differentiate between pseudo progression and the true progression, especially in PET MRI, how can differentiate between pseudo and the true? Only by biopsy or tumor size increased, but it is pseudo, not.
You are talking about head and neck or brain tumor?
Any tumor.
I will talk about head and neck.
Even in head and neck tumor.
Yes. The first follow-up after treatment, especially in the MRI, there is a lot of pseudo progression phenomena. So if I don't have a frank residual or a frank progression, so I will keep it as a post-treatment change till the next scan. This is my strategy, and this is the ACR. We also have 1F and 2F in NIRADS, but I didn't mention. F means the first follow-up, which has a lot of pseudo or post-treatment change that may mimic the residual tumor. If we are dealing with brain tumor, we have a chance to do more advanced techniques like spectro or so what. But in the head and neck, this is to some extent limited due to the complexity and air, bone, and soft tissue. This hinders the advanced technique to some extent. So my strategy, if there is no frank progression or residual, I will keep it as a post-treatment change and ask for the next follow-up to be more specific.
Thank you.
Thank you, Dr. Togan. I would ask you about the timing of imaging. Patients post-surgical intervention, we need to have the decision for adjuvant treatment and to start within 6 weeks.
8 weeks.
Yes.
Yeah, we need 8 weeks. Then we can image so that the hyperemic change and soft tissue edema is at least, and not to postpone the treatment of this patient. I need also the pre-treatment scan, very need to it, to differentiate the residual tumor, as it will mimic the initial tumor to some extent. and compare this early post-operative scan, which is deceiving to some extent, with the pre-treatment study.
Thank you.
Yes, please.
Again, Assalamu alaikum. Thank you for your intelligent presentation. Continuity to Dr. Osam, what he asked about pseudoprogression. We have a very good experience with brain MRI unit that we are asking the technique of radiology in the recurrence to have a brain lab to imaging the patients in the XYZ 0 angle of gantry to be integrated in the radiotherapy technique because we have a nowadays era of re-irradiation in head and neck tumors, re-irradiation of brain tumors, either by IMRT or advanced techniques. So in vision of re-irradiation of head and neck tumors, are you apply imaging of the patients not in the tangential way like you do usually in the sinus view in the imaging to cut it in the axial 0 angle XYZ to be integrated in the radiotherapy? I asked this many times from brain MRI, but head and neck is first time to ask this option.
Yes, we do it.
Yes.
According to the clinician request, we can do it, but after your request. This is
Yes.
not the routine,
Yes.
but we have a lab, you mean lab protocols? Yes. Yes, we can do it according to the clinician request.
By this option, we will use functional imaging in accurate delineation in the radiotherapy. So we have two main goals in this strategy is to diagnose and use this diagnosis in the delineation of head and neck tumors. Thank you.
Please.
Sorry, I'm Hoda Bouz from the UK. Just wanted to go back for your question about when to do imaging post-surgery. The question is there a need to do imaging post-surgery? Because if the patient has been already staged very well before surgery, and the decision was to go ahead with primary debulking surgery, head and neck surgery, which is fine, your decision about adjuvant treatment is in fact entirely of pathology. So what is the pathology? What are the, in fact, what are you going to talk about in terms of the margins, the grading, lymphovascular space invasion, and you knew pre-surgery that if you had nodes or not. So nothing is going to change. The rush should be for the adjuvant treatment. And in fact, if you're going to be waiting until we are all right to do, I totally agree. If you want to do any imaging, you're actually needing about 4 to 8 weeks for the tissues to settle to be older to image. But in fact, from our point of view as clinical oncologists, if you actually want to make a decision, if you want to give adjuvant treatment, why should you be staging again? You shouldn't. There is nothing is going to happen in those 4 to 6 weeks.
We want to check if there is a residual and for dose of radiotherapy. Unfortunately, we show multiple patients with residual disease in the tumor bed, and we have to give 70 gray and concurrent for these patients. We need for imaging to be sure if this is a post-operative changes or a residual tumor.
Okay, so if you've done your surgery, so you've staged the patient, you've done your MRI, PET CT, whatever. The patient had surgery probably about 3-4 weeks after your imaging, and you need to give the patient adjuvant treatment, whether that's chemotherapy or radiotherapy. I can understand if you're going to stage the patient to see if the patient has got metastatic disease, if you haven't done this prior to surgery. But locally, if the surgeon tells you that in operation, they have done the whole operation, all the tumor is out, your pathologist told you that there is no positive resection margin, the resection margin is clear, then actually any imaging post-surgery is a delay for the patient. You should not be doing it, I think, personally, and this is our practice. And I'm raising my hand. I'm actually, practicing in the UK. We are very difficult with money. So, you know, this is a waste of money really to do another imaging. One of the points your point about if there is residual disease, can you not see it on your planning CT scan? So you're going to be doing, you're actually imaging the patient to give them radiotherapy, aren't you? So if you're doing planning CT scan and you're doing it with contrast, then you are going to be seeing if there is any residual disease because you're only imaging the local area that you're going to be treating. So there is no need for further MRI scan and another delay waiting for it to be reported. The decision definitely is going to be made from pathology, your histology, and also your planning CT scan.
This is true if you can trust the pathologist and the surgeon.
Yes.
But the situation is totally different here in Egypt.
Say that again, sorry.
The position is totally different here in Egypt. Sometimes you cannot trust both.
No, I totally agree with you. This is over investigations we are wasting our time and wasting our resources with. Although there are some few scenarios that you have to refer to diagnostic imaging before starting radiation therapy. My question actually, at the clinic, after treating nasopharyngeal carcinoma patients, sometimes you don't have any enhancement at the mucosa, no enhancement at the mucosa of the nasopharynx, but you might have some activity submucosa at the submucosal space on PET-CT. And of course, frequent biopsies usually comes negative because after a high dose of radiation therapy, the surgeon feels hesitant to go deep to avoid bleeding. And unfortunately, the radiology report usually is not directing us the right way. It describes what is there and it leaves us with a statement that for clinical correlation. Is there any other mean not to have such situation and to direct us more smoothly and safely for further management of such finding?
You asked me about the nasopharyngeal carcinoma after treatment. So we don't have enhancement in the mucosa, but we have uptake in the PET-CT. This is accepted for the lymphoid tissue. So I don't recommend to do a biopsy. This is maybe a physiological uptake for the lymphoid tissue, or maybe the post-treatment change. If there is no correlation with the anatomical images. I look to the CT without the PET-CT or the MRI. If there is focal mass, focal thickening, nodular enhancement, so I will consider this as a residual disease and I will consider the FDG uptake. But if there is no, and there is only mucosal pattern of enhancement, smooth, no nodularity, so this is the uptake of the lymphoid tissue or the post-treatment change. If you are worried, we can do it as NIRADS 2, in which there is discordance between the PET-CT and the anatomical or the cross-sectional imaging, and this is the further management is to do follow-up, but not the biopsy.
Thank you very much.
Thank you.
Any further questions?
Thank you, Dr. Tugan, for this very comprehensive presentation. I want to introduce myself. I'm not a clinical oncologist. I am a head and neck surgeon, otolaryngologist. If you are going to treat the patient during the follow-up, like for example, the patient with cancer larynx without a positive biopsy, I don't agree for this. I'm not going to accept to treat a patient having salvaged total laryngectomy with just a positive imaging. And so even for a patient with nasopharyngeal carcinoma, I will go ahead and have a biopsy. And the best head and neck surgeon should be available at that time to get the biopsy from the tissue that will not be fibrotic or whatever. And the best pathologist should read these slides because they are very difficult post-treatment, usually the identification of a living malignant cells, or to say that this specimen is sterile or non-sterile, needs a highly specialized pathologist. But I don't agree to treat the patient and to have radical decisions without a biopsy, even if I have an IRAD 4. I think that the NIRAD has to be going parallel with the surgeon's view, especially for endoscopy, because sometimes you may have a NIRAD 2, for example, and you're finding a mess in the larynx, you are finding an ulcer, you are finding a patient with severe pain, not responding to treatment after being completely relieved. So sometimes you can have a NIRAD 2, and I can go to the theater and have a biopsy, because clinically, endoscopically, and by my examination, I'm highly suspicious. So I think the NIRADs has to go hand by hand with with endoscopy and with clinical examination, clinical picture of the patient, and to take a decision of treatment, especially in those mucosal surfaces. I think that biopsy is very important.
Yes, I agree with you.
Thank you very much. Any further questions? By this, we'll close this session. Thank you very much for your attendance. Thank you.